deliberate the moving forward in order to, I just got a message that we're recording, that's okay, in order to steward our shared fate. And the history of this event is, interestingly, a story of the COVID-19 pandemic itself. Dr. Irwin Redlener was originally set to come for 2 days at the invitation of President Michael Drake. President Drake, knowing that Irwin was in brain. So in January, when we initially planned this event, we were just beginning to understand the seriousness of the outbreak in China. And it appeared that, it seemed at that moment that the question that Irwin ought to address is, are we prepared? That question took on more urgency as this novel coronavirus spread. So we booked a bigger room. We reached out to arts and sciences, to veterinary medicine, to the law school, to the Risk Institute at business school. This is an event that reached across our collective expertise. And certainly we only represent a fraction of that expertise, but it's important that we had so many people coming together today. And now, of course, we need no longer ask that question, are we prepared? We know our answer to that question. We're not prepared as a nation, we're not prepared as a globe. And that's where our focus is going to be today, talking about science and policy at the levels of cities, of the world. The role question that our keynote speaker and the OSU experts will be addressing today relate to 4 key areas that help us think about this moment. And for those of you who don't have your mics, yourselves muted right now, can you please mute? So speakers, will make sure you have time to unmute before you start. Thank you. So from the operations questions are now no longer, are we prepared, but what where do we stand, and what lessons must we take from this experience, not only to prepare possibly for the fall, but for the long-term future? In terms of the science, what do we know about the virus now that we didn't know in December and January and February that can begin to help us predict where we might start to relax social distancing measures, when, and over what period of time? From the perspective of ethics and law, to me, the central question crisis. We have often probably heard it said that we're all in this together. But how do we make that true? Some populations face a kind of triple whammy. Folks like janitors and restaurant workers and bartenders were and are more at risk. They're the least likely to have paid sick leave and the least likely to have adequate health care. And now they're amongst the millions who are unemployed. Asian American populations have also experienced the pandemic in ways with deep historical stigmatization, bubonic plague, smallpox, even tuberculosis have historically triggered not only discrimination, often seen in the form of scientifically unsound policies cordoning off Asian American communities, but also acts of violence. And the same is true today. So how can we truly ensure that we are all in this together and that we share the burden of sacrifice for the good of the whole, and that no population is stigmatized or unfairly targeted?
Jen, you're going in, Amy, you're going in and out there.
How do we recover? Sorry. Can you hear me now?
I hear you, but there's like blank spaces where your audio is not coming across. But
can others hear me? Thumbs up if you can still hear me. For the most part. So I think we're just going to have to work through some of the difficulties. And so a last bucket of questions really revolve around recovery. How do we thrive as communities, as an interconnected global? Give a quick sense. Dr. Redlener will provide about a 20-minute keynote that's going to set the stage for us. And then each of our OSU experts will take no more than 10 minutes to address the most pressing questions and issues in their fields. And I'll introduce each of those speakers before they speak, so you'll know at the outset who that person is. The group will take questions at the end, but we're having all questions come up through the chat feature, and then somebody is going to the most frequent and the most relevant question. We have many participants. We'll only be able to ask a fraction of the questions, so we'll be looking for questions that this group can answer about city, state, national, and global level issues, as opposed to more granular questions that some of us at OSU might have on our minds about this particular institution. So with that, Irwin, I hope you can hear me now, because I'm about to introduce you. I've had the pleasure of knowing Irwin for at least a quarter of a century.
Yes.
He funded, remains the most downloaded and cited paper in my own academic history. It was a paper on the ethics of mandatory evacuation. Dr. Redlener is a nationally recognized expert on children's healthcare, disaster preparedness and policies, and the impact and consequences of major natural disasters and terrorism, and the relationship between disaster resilience and sustainable development. Among many other things, Center for Disaster Preparedness, Columbia University's, which works to understand and improve the nation's capacity to prepare for, respond to, and recover from disasters. In addition, he holds professorships in health policy and management at Columbia's Mailman School of Public Health, and in pediatrics at the College of Physicians and Surgeons of Columbia University. He currently serves as a special advisor on emergency preparedness to New York City Mayor Bill de Blasio and numerous federal agencies, U.S. Department of Health and Human Services. That one, I'm going to hand things off to you.
Okay, Amy, I'm gonna share screen right now, and hopefully, if somebody just could confirm that the PowerPoint is visible. Is it? We're good. Okay. You know, I just finished working on this presentation yesterday, and I've already given it twice at the Earth Institute of Columbia. But to tell you that every 6 hours, we're getting information through the fire hose of research, data, epidemiologists, modeling, etc., would not be overstating the reality of what's going on. And that, of course, has had consequences for the people that are responsible for actually making policy. But I want to go through this, and it's some basic information, and then it'll hopefully stimulate some questions, and I hope we'll get to as many of them as we can. So first of all, just to give a sense of scope and scale here, I took New York City as an example, but you could basically take any city and just plug in the population, but New York City now has a population of about 8.5 million. Many, many modelers and virology experts believe that at least 50% of the US population will get infected with the coronavirus that causes COVID-19. And some people think it's going to be higher than that. But the important point here is that the vast majority of people who do get infected with the virus will have either no symptoms, mild symptoms, or manageable symptoms. So let's say 50% of New Yorkers do get infected. We're talking about over 4 million people just in this city that will conceivably, if not more, have the virus, and have the virus in some level of severity from 0 to ICUs. The hospitalization rate, taking a relatively low number used by modelers. I'm going to talk about modeling in a little bit, but let's say we say 5% of the people that need hospitalization, who have the infection needing hospitalization, we're talking about over 200,000 people. And of those, somewhere in the vicinity of the low 50,000s will need to be in the ICU, and a large percentage of those will need to be in the ICU because they need mechanical ventilation support to help with breathing and supporting their basic physiological needs. So we're looking at a big load on the ICUs, and this, of course, is just in New York City. And you could do, like I said, the same calculation in Columbus or Seattle or anywhere else. But basically you're plugging these assumptions into formulas that will help predict and help people plan. One of the big questions is, what is the fatality rate of this illness? And just as a benchmark, we know that somewhere between 20 and 30 or 35,000 people die every year of seasonal flu, influenza A or B, and this is why we get our shots. So there's going to be some multiple of that, and there's been a lot of numbers thrown around by, people like the President of the United States, who yesterday in the press conference said, sort of confirming what Dr. Fauci from the NIH is saying, that we may get 100 to 200,000 fatalities from this illness. But if we don't do what I've done, if we hadn't done what I've done and will continue to do, we could have deaths in the 2 million range. And there are some modelers who say that it's possible if we did not intervene with any kind of public health intervention. So we do have numbers flying out there, but the fatalities in New York City, because the modelers don't all agree, it'd be hard to say exactly right now of how many fatalities there would be either nationally or in any given city. But if we knew magically, if we had the tests done already available, and we knew what the denominator was and what the death rate was, we could figure out the case fatality rate. So that means that if we had 200 million Americans infected at all levels of infectivity and clinical signs, and then we're going to be dealing with a actual fatality rate overall of less than 1%. That doesn't take into account people who are particularly high risk. So older people, especially people in their 80s that have to go into an ICU, are going to have a very, very high fatality rate. But for most people who get mild symptoms or no symptoms, the fatality rate is going to be much lower. So this remains, I would say, a work in progress. In terms of some general points I want to make, there's two of them worth thinking about. And although we can say that for sure that the COVID pandemic is going to have an enormous consequence for the people that actually get infected and for the healthcare systems, it's important to know that patients who do not have COVID-19, but who need medical care, are also going to be at risk, because the COVID-19 onslaught is going to affect every level of care from low to high. So that people who need urgent hospital care not related to COVID, so I have severe chest pain, I have what may be a stroke, I have some serious trauma, and I need to go to the emergency room, they're going to find that the emergency rooms in many places will be overwhelmed with COVID patients, as will the ICUs, the surgical floors, and so on. So that's one group. The other group are people who are not going to the hospital, but they have very important chronic illnesses, severe hypertension, longstanding coronary artery disease, diabetes mellitus, who actually need their primary care and specialty care relationships. They are going to have trouble getting that care because many of those offices are closed for obvious reasons, and many of the medical staff have now volunteered services at the hospitals. So for people that have these very serious chronic illnesses, we're going to be squeezed. I'm saying we, because I would fit in that category. We are going to have trouble getting the kind of care that we're used to. And certainly things like routine care, like a checkup without having any symptoms for any age group, is going to have to be extremely limited. And the third category, I'm making it separate because it's worth talking about it separately, is that there are people with primary illnesses that affect their ability to fight off infections, their immune system. And those people are obviously going to be particularly vulnerable and need to be particularly careful about avoiding any contact with people other than in their intimate family, nuclear family settings. But those people are at high risk. But there's a lot of people that are taking medications for an illness, that the medications will have an effect on limiting immune response as well. So people that have ulcerative colitis or Crohn's disease that are on steroids, even very weak steroids. I know people on Crohn's disease on 3 different medications, 2 of them orally, 1 of them by intravenous infusion, who have very serious impediments in their immune response systems, and they're at high risk. So this world of the non-COVID patients worth talking about, because that will also be those people will be very affected by the system's breakdown. Second general point is that you've probably heard about this flattening the curve idea. And what does that mean? It means really public health interventions or guidelines that will that have a goal of reducing the spread of disease. So if you're going to be, if you're not symptomatic and you're staying in your home for whatever period of time, you're literally following all the rules. You're not going out. You're ordering in food. You're cooking at home, etc. Then you have a pretty good chance of not contracting the disease, and at some point limiting the total number of people who need hospital care. But the other thing about flattening the curve is the curve, in the absence of flattening, looks like a very steep climb. And when it reaches its apex of many, many patients needing hospitals or ICUs, that represents a threat to the integrity of the healthcare system, because most places won't be able to handle it. So one of the ideas about flattening the curve means to spread out the occurrence of people with COVID who need hospitalizations. So let's say instead of getting 300 admissions a day that need hospitalization, the public health interventions like isolation and sheltering in place may drop that down in half, let's say. So the system is not as overwhelmed as it could be. These public health interventions also have a possibility of reducing the total number of people who actually get infected. There's some serious questions about when to start reducing or eliminating the restrictions, and I want to get to that in a moment. What's coming? What are we actually facing? I just want to run through a few things that have been on my mind, unfortunately. It just affects everything, sleep and what I'm thinking about every day, but this is what it is. So at the end of February, I wrote an op-ed in the Washington Post. It was about a deteriorating war situation in northern Syria, that the Syrian army was really putting the pressure on, and a lot of civilians were displaced and in absolute fear for their lives, and legitimately. And I talked about that new level of crisis in northern Syria, and then postulated what would happen if they had a serious outbreak of COVID-19 in northern Syria, or in any conflict zone, but let's say northern Syria. Syria's healthcare system has been extremely deteriorated by constant attacks, deliberate bombings of hospitals, and so on. So 53 hospitals have been lost. So not only could that area and the civilians there experience a massive outbreak of COVID-19, their healthcare system is not even remotely ready to deal with that. And that story could be repeated in every large refugee camp and internally displaced persons camps, people, basically refugees in their own countries. The outbreaks in those places that are already very limited in terms of medical care that could be available represent very specific challenges. To that point, in the US, there are many communities that are not going to be immune or not vulnerable to the COVID, because there's no reason why they would be, except that HPSAs, Health Professional Shortage Areas, which are a federally designated piece of data that says how many people live in areas where there's insufficient supply of hospitals and primary care providers and so on. So there's over 6,500 federally designated these shortage areas, where at least 60 to 65 million Americans live. There's nothing even pre the COVID crisis. They're living in areas where it's really difficult to get health care. But as those areas, more isolated, less access to health care, start seeing outbreaks, they're going to be in even more trouble than they are in routine, in a normal situation pre-COVID. And as always, this is always necessary to say that people who are highly vulnerable because of age, poverty, they're marginalized, they're undocumented, whatever it is, all of these people continue to be hyper vulnerable to getting serious, having serious problems in their communities with COVID. Something else that we need to think about. And nobody can avoid, if you're up and awake and watching the news or reading news at all, that there's been crazy impact on the economy of the US. So let me just say, I'm nowhere near an expert in economics on any level, but we watch the stock market and our 401ks go, up and down and up and down. We're looking at unemployment numbers, and it's just pretty frightening. And that's something that we obviously we need to be dealing with. But more importantly, from an economic point of view, is, to me at least, is the economics of a family. Low income, middle income families, and people who need their paycheck regularly and reliably to pay the rent, buy food for their family, and so on. I'm very, very concerned about them, because we can't ask people to isolate, shelter in place, and let them have to contemplate the fact that they may be evicted, they may not have enough money to buy food. This is something that can be dealt with, and this is why the relief packages that the Congress has passed recently, and there's going to be more of them, must focus on making sure that low income or low middle income families will still get money. They need to get a lot of money. They need to be able to survive, because if we're asking them to adapt to these strange situations, we have to make sure that they don't have to worry about economic issues. People that deal with sustainable development and economically rising nations, they end up with a serious COVID outbreak, are going to see a significant backsliding in what their development trajectory had been. That's really important. And finally, Italy. And I think most of us in epidemiology and public health see that we're, in the US, 10 days, 2 weeks behind Italy. So the collapse of the healthcare system in Italy, even now with pretty stringent control methods from a public health point of view, is seeing this very dramatic collapse. And this, on the right, is a picture of Elmhurst Hospital in New York City. And you've probably seen this on television, but we're headed from Milan to New York City. And generally speaking, that's what we're seeing through our front windshield ahead of us. The challenges that we're facing right now, I just want to breeze through these, but the unconscionable, inexplicable failure of the federal government to produce and distribute reliable testing months ago has been a problem, because we don't know the denominator. We don't know how many people are infected, and we can't track them, and we can't track how many get really sick, and we can't do accurate predictions of what the healthcare system's going to need. Right now, I guess places like Abbott Labs and other organizations are producing in large quantities the testing information, testing capabilities, but we're far behind. And it's no sense beating a dead horse right now, but at some point there is going to be a postmortem about what happened with this, but we were left high and dry. And comparatively to other countries, it's been a really international embarrassment that we haven't been able to get this right for so long. Then messaging chaos is how I describe what we've gotten from the White House. I don't know for how many weeks the president was saying it's all under control, this is going to be gone. In April, we'll have a miracle, and that'll be the end of it. And then 5 seconds later, Tony Fauci from NIH will get up and say, well, actually, it's going to get worse before it gets better, et cetera, et cetera. And in terms of federal guidance to states and cities, it's been all over the map. It's been very mild suggestions when the states and cities needed explicit direction from the White House, POTUS, President of the United States, and public health experts. And since we didn't have that, what we've had is what I'm calling random acts of preparedness and response. And that's what it is, because we had the mayor of Seattle say, no crowds bigger than 250 people. She said a few weeks ago, New York City said 500 people. Now everybody's saying 2 people. And we could have gotten to where we needed to be a long time ago if we had consistent, non-conflicted recommendations and guidance from the government, federal government. Hospitals are ill-prepared. I don't need to dwell on this. Supply chain has been mismanaged. The Defense Production Act is just now starting to be enacted a little bit. It should have been enacted a long time ago. The country's going to need 3 billion with a B face masks over the next year. So people are working on it, but we still have, everyday hospitals stressed, trying to make sure they have the basic protective equipment that they need. My son, Michael, is a doctor and supervises 2 different emergency rooms and 2 large ones in the ER. And the daily conversations with him are deeply painful and frightening. And it's just a situation that we should have been far better prepared, but we're not. The inconsistent modeling assumptions. So modelers, for those of you who don't know, are these people that are brilliant, and they take assumptions and they make projections. Where are we going? What's going to happen here? And I'm seeing over the last week, actually, more differences among modelers than I think we were seeing before. That's a problem. It results in more random acts of preparedness, because if the mayor is looking and speaking with this group of modelers versus the other group of modelers, he may be getting a very different set of data and information that's going to dictate a particular policy that another group of modelers would say, no, well, we're not so sure about what you just announced. This is not good. I don't know what to do about that. I'm going to maybe try to call for some meeting of modelers, although they're meeting in their little subgroups of people who know each other and have worked together before. We're into the battle now of the public health community and the economists. And I don't know how this is going to play out, but the people that are focused on the economy want the country back to work, and you can understand that. The people in public health want people to be safe. We don't want them to leave their house. If they can work remotely, good, like we're doing right now, but this will be playing out. I don't want to dwell on this. You might, of course, just about it later. And then, of course, we're in the race to produce effective medical countermeasures and vaccines. Vaccines still a year and a half away. There are about 200 labs worldwide that are working on countermeasures, like medicines that are specific for coronavirus. But, we have a problem here, because there's a lot of rumors that are being acted on. This issue with chloroquine and hydrochloroquine. Medicine's been around a long time for malaria, or azithromycin in combination with chloroquine. None of this has been sufficiently tested. We're not sure what's safe or what's effective, but it's become like almost a cult following of people who think we should, be taking chloroquine or high doses of vitamin C, et cetera, et cetera. So in a situation where there's a lack of proven information, people are turning to the internet and social media and finding all kinds of things out there. But even governments are talking about, why aren't we using things like chloroquine? The reason is it's not proved to be safe and effective with the coronavirus. And finally, and it's related to what I was just saying, that we have to be constantly vigilant about bad science and exploitation and BS and social media, and everything we do to neutralize that is good. So what we're basically saying, our mantra is, you want information, go to the CDC website, go to your local health department's website, and there's where you're going to find the most reliable information. People should be staying away from social media as a source of reliable information. So we're coming to the end of what I want to say. But what we're dealing with here is a real adaptation to a very, very strange and surreal situation that none of us have ever experienced unless you somehow you're born well before 1918 and were awake and alert and living through the Spanish flu. This is something we haven't seen, period, in our lifetimes. We have to be resilient. We're learning how to do that. How do we stay sane amid all this disruption and uncertainty and fear? And what is it that we're doing? What is adaptation? How's our family life changing? How are we keeping our children educated? What do parents need to know, et cetera, et cetera. But you know, at the end of the day, when this is all over, we may be learning some very important lessons in adapting to crisis. And our children will be watching us, maybe not speaking, but they're going to be absorbing what's going to go on over this next few months. And it's really important that parents understand their role in trying to make this experience manageable by their children. They're going to remember this for the rest of their lives. So I'm going to leave you with a few questions. Should we have a national shelter-in-place program? I think yes. There's mothers who think no. I'm just leaving that as a thing. What happens if shelter-in-place program ends and is followed by severe outbreaks? So if you're sheltering at home and you're negative for COVID-19, and then you go out at some arbitrary point, you're then going to be immediately exposed to people who may have the COVID-19 disease, and we may see a big uptick, a surge in cases if that happens too soon. So we don't know when we're going to end sheltering in place and what happens when we do. I want to mention also this horrendous problem for our medical care system, which is that we're now in what's called crisis standards of care or altered standards of care. We're moving to combat medical triage versus civilian triage, meaning that at some point, if we get too overloaded, we're going to have to say, you know, we're going to give our limited assets to people likely to survive, and take them away from people who have less opportunity, less possibility of survival. This is a bioethical nightmare for most doctors and nurses and medical teams. You know, grandma may have her ventilator taken off to be given to a younger person, and that's antithetical to how we generally handle medical care. And what about grandma? We got a lot of people that we care for. We have older relatives in nursing homes, which we now cannot visit. Many of us have older relatives living in our homes with us. This is a big challenge. They're a tremendous risk. And if you have the disease and are not symptomatic and not aware, you can still transmit to the virus to high-risk individuals. So how and when and how will this end? Will good come of this crisis? The main thing, this is really the final point. If we come out of this situation with a new appreciation for the necessity of the international community needing to cooperate and collaborate to solve the major planetary challenges that we've been talking about for a long time, like the climate crisis, biodiversity, environmental issues, conflict resolution. If this terrible situation results in that end, a whole new way of international cooperation, that would be a wonderful thing. No one can guarantee that will or won't, but I think that's what we're heading towards. So let me stop share here, and that's really what I wanted to say as an introduction, but look forward to questions now or later, Amy, whatever.
All right, thank you. So we'll do questions at the end, and when we get to that point, I'll try to, because there can be some chaos and everybody jumping in at once, I'll try to pitch you each a question and make sure that everybody's covered, but also try to start a dialogue between you as much as we can. So if anybody has joined us midstream here in Irwin, Irwin and Phil, if I could ask you both to mute. So the COVID-19 forum being hosted by the College of Public Health at The Ohio State University. I'm Amy Fairchild. I'm Dean of the College of Public Health. And you have just heard from Irwin Redlener, who is the director and founder of the National Center for Disaster Preparedness at Columbia University's Earth Institute. So we're going to hear
Amy,
next.
Amy, I'm sorry, Amy, I should have mentioned this earlier to you before the thing started, but one of my sons was actually admitted to the hospital yesterday with COVID. So if I have to get off, that's why. But just want you to be aware of that. I might have to.
So Irwin,
take a call.
Okay, Irwin, thank you for sharing that. I'm sorry. I speak for all of us in expressing our concern, and our thoughts are with you during this period of time. I know this is scary for everyone, regardless of where we sit as we think about and deal with and manage this pandemic. We're going to hear next from Dr. Mike Oglesbee. Speak for each about 10 minutes. Dr. Oglesbee is professor of virology and comparative pathology, and he is also the inaugural director of the Infectious Disease Institute, the IDI, at The Ohio State University. The IDI consists of 6 interdisciplinary research networks or programs that span 11 colleges at The Ohio State University and the Research Institute at Nationwide Children's Hospital, and includes over 220 faculty. So it's a real gem in the crown of the IDI is to combat the challenge of diseases by bringing together a range of disciplines from basic to translational, with a focus at both the individual and the population level. They focus on modeling, microbial ecology, and prevention, as well as treatment. So Mike, can I hand things over to you for about 10 minutes with comments now? Thank you.
Yeah, thanks, Amy. I am going to comment on the modeling predictions that are allowing us to address the initial surge in cases. And then I want to transition briefly into what we're going to do in the interim as we await development of a vaccine. As Irwin's pointed out, that's about 18 months out. So there's a lot to be done between the initial surge in cases and the ultimate launch of a vaccine. And then I'm going to conclude with just a couple of comments on how we should be thinking about these emerging diseases looking forward. So we've really covered a lot of ground since December. December was the time in which the epidemic of pneumonia was identified in Wuhan, China. January 5th, it was identified as having been caused by a coronavirus, so we call it a coronavirus disease. 2019, that's where we come up with COVID-19, and also identified the viral agent, which we call the SARS coronavirus 2. And SARS is the acronym for Sudden Acute Respiratory Syndrome. January 21st, the global spread begins, and now, as of March 26th, we have over 500,000 cases worldwide, impacting 175 countries. So to reiterate, Irwin's overriding theme, yes, we were unprepared, and surveillance, disease surveillance was the key deficiency. I say disease surveillance is also virological surveillance, serologic surveillance that was lacking. So we are using the data that we do have to predict the initial surge in cases as we have a virus that's unleashed on an immunologically naive human population worldwide. And that modeling is required to both anticipate threats and to respond to the threat. So are containment strategies effective? Do we have the healthcare infrastructure in place to address the challenge? And I believe, and this is the IDI perspective, that teams should be interdisciplinary. And I'm focusing here on how to anticipate the response to the surge that's occurring. We need expertise in epidemiological modeling, microbial risk assessment, geospatial modeling, and bioinformatics. We can't have it coming out of one sector alone. And we're launching this through partnerships between public health, hospitals, and individuals at our institution, so academic investigators. And so currently our modeling efforts are supported through a partnership between the Infectious Disease Institute, the College of Public Health, the Ohio Department of Health, the Ohio Hospital Association and the Wexner Medical Center. So first of all, I want to put this one to rest. There will be a surge. Getting back to Irwin's comments on different modeling predictions, there are some models that suggest that it's all gloom and doom. There are some models that suggest the problem's not so acute. I think it's pretty clear that there will be a surge. We have an agent that's more infectious than influenza. In these different approaches to modeling, the one that we've embraced is a contact network model for the surge. And this says that exposure of susceptible individuals differs between and within networks. And by networks, I'm talking about communities of people. And our approach is to actually model the effects of disrupting these networks through social distancing. And we all agree that social distancing is the most effective thing we can do right now. So the one we're working with is a learning model and is focused on symptomatic test positive patients. And so by a learning model, what we're doing is saying, what did our model predict yesterday? What are today's data? And now we make adjustments to the model in real time moving forward. So the numbers right now, in Ohio, our first case, or first 3 cases were diagnosed March 8th. We were fortunate to have a governor that was very proactive and DeWine closed schools on March 12th. But despite that, we can reasonably assume the infection was already pretty well established. And so by March 30th, yesterday, we had 1,900 cases and 39 deaths. The network model predicts a peak in incident cases in the 2nd or 3rd week of April. And that peak will represent 10,000 new cases on that day. And the cumulative number of new cases over this surge will be about 210,000. Now, here's the point that's really important to take away. Had we not implemented social distancing measures, it's predicted that that number would be 375,000. So it's important to measure the projected impact. We're looking at about 20% hospitalizations based on these test positive symptomatic patients, and 1/3 of those will probably end up going to the ICU, and 1 to 2% will succumb. So this is really important for hospitals to predict need. There will be outbreaks following the surge. So this is just the initial hump. And so now we're looking into late summer and autumn. So as I mentioned, we have every reason to believe an effective vaccine can be developed, but that's 18 months out. What do we do in the meantime? Well, for one, we ramp up surveillance for viral RNA to identify hotspots so that we can focus our containment strategies. I believe that our containment strategies will change. It won't be the global, basically stay at home. There'll be more contact tracing. And we'll use this enhanced surveillance to protect healthcare workers and hospitalized patients. That needs to be a priority. We're expanding test centers. We're now, in Ohio, we've tested 27,000 samples, which is an incredible increase from the beginning of the month. And we're changing that turnaround time from what started out as up to 10 days down to 1. There are point of care tests for detecting viral RNA that are coming online. And I think Irwin mentioned Abbott's efforts. So we should be able to go from 45 minutes from sample submission to test results. And the FDA has provided emergency use authorization for hospital use for these tests. Serologic surveys are going to be important to enhance the understanding of infection prevalence. And individuals recovering from infection should have at least short-term protective immunity. And this will allow us to identify those at minimal risk so that they can return to the workforce. The seropositive individuals can also be used as a source of antibody that can be used to treat others that are suffering from severe and life-threatening disease. And we call this passive immunotherapy. There's proof of concept with the original SARS, with Middle Eastern respiratory syndrome virus, and with H1 influenza. And the FDA is granting clinicians permission under a single patient emergency IND, the investigational new drug application. So a lot of effort is going to this. As far as treatment, I think the antiviral that holds the most promise is a nucleotide analog. It's a nucleic acid that basically fools the viral machinery that's required for replication of the virus's genome. And as Irwin has pointed out, the issue of chloroquine, hydroxychloroquine, we just don't have the data. I think that's more of the, gee, I hope it works. Whereas I think the nucleotide analog, we have more direct evidence. And then I want to conclude on the management piece. I think the real impact is going to be on fighting the host response to infection. Because what we know now is really that it's an overly aggressive inflammatory response that causes the acute respiratory syndrome. And so we need to focus on really blocking the aspect of inflammation that's excessive. So looking ahead, we need to increase focus on how new infectious diseases emerge. I mean, 70% of these diseases arise from animal reservoirs. This is really the second arm of predictive modeling, and it should be the first. The current situation should not be a surprise. We have ample evidence of emergence events with the original SARS, with the Middle Eastern respiratory syndrome virus. We have numerous examples of emergent coronaviruses in pigs. And the challenge of these emergence events will only increase as a result of increased human population densities and environmental degradation that increases contact with animal reservoirs. So coronaviruses are ubiquitous. There are multiple types and multiple species, and there are barriers to spread between species, but these spillover events between species will continue to happen. And so we need to maintain a basic research focus on spillover events. There are lessons to be learned, so many lessons to be learned. We have a bovine coronavirus that behaves very similar to what we're currently facing. And so in the end, my take home is that we really need to maintain vigilance in the absence of disease. And I think that's the hardest thing for us to maintain. The problem goes away, we forget about it, and we cannot do that.
Thank you, Mike. We'll come. Sure. And one thing I've seen us forget time and time again as a nation and as a globe. So for those of anybody who's just joined us, that was Dr. Mike Oglesbee. He is the professor of biology and comparative pathology, and he is the director of the Infectious Disease Institute at The Ohio State University. You are part of the Ohio State University's College of Public Health COVID-19 Forum. I'm going to turn now to Marc Spindelman. Marc is the University's Moritz College of Law, and I think we have a couple of panelists who may need to mute. Professor Spindelman regularly teaches courses in constitutional law, family law, and has taught courses in bioethics and public health ethics. Prior to joining OSU, he had been a federal appeals court clerk, an associate at a Wall Street law firm, and a Lewis Fellow for law teaching at Harvard Law School. And also he had been a Greenwald Fellow in bioethics and health at University. So thank you for joining us today. I'm going to mute myself and let you take things over.
Thank you, Dean Fairchild. It's lovely to be here, although obviously under very sad circumstances, but thank you for building the community. I'm glad we're all here today. Community matters. I'm very thankful to be in community like this with all of you. As Dean Fairchild said, I'm a law professor. I teach and write about law. Today, I want to talk with you about the moment that we, women, men, and non-binary folk are living, and the potential that it has to alter what we think about, need, and get from the law. In many ways, what we're collectively doing in this moment of crisis is remarkable. It's going to change how we live. Nobody knows all the ways. We aren't only now busy caring for ourselves and our loved ones as much as we are doing that. The social distancing and isolation we're practicing is itself a great heroic act of civic friendship. We're filling in the spaces between us with shared fundamental values of relationships and of caring for the welfare of our communities. Examples of civic friendship abound. Thinking locally, emergency personnel, nurses, doctors, and other healthcare providers, and first responders of different sorts are daily taking risks to their well-being in order to care for and engage with total strangers who are or may be sick. So too are workers working all along newly reconfigured supply chains and other laborers supplying essential services. These folks didn't sign up for hazardous work at non-hazard pay, but they're showing up shift after shift and doing it just the same. Our students, including law students, are showing up too, outside their classes in some new ways. I've recently learned about how some of our students are undertaking community work, appropriately socially distanced, involving mutual aid with strangers with needs. Mutual aid, a type of civic friendship that can trace roots to Federalist Republican traditions, is neither charity nor professional nor non-for-profit work. Aid is among equals. It recognizes that needing is part of the human condition, distinctively but not only in crisis. Figuring out what our needs actually are and asking for help in getting them met can itself be a gift that allows another human being in to meet the need that stands ready to be met. Exchange in this setting is mutual, equal, dignified, respectful. Done right, these exchanges aren't transactions, but practices in new ways of witnessing and being with ourselves and others. Political ideals like mutuality, equality, dignity, and respect don't refer here to how governments should treat those it rules. These political ideals are embodied civic practices that manifest in us, inside of us, and in relations with others. The civic friendships that result can change us as they change the social worlds we co-create, worlds that hold us together in crisis moments and beyond. As I've learned when trying to experiment with practices like these in my teaching and writing, it's easier to describe this work than actually do it, especially well. Then along come these students working it out in real time. There they are, building platforms that invite people to name and claim needs around food, finances, shelter, that others in the community are invited to meet. Strangers helping strangers this way locally forge new friendships and communities with ever-widening ties across the state. It feels right to thank and to honor these students for their work, including for the teaching that it does, and the question that it asks us to ask ourselves through its example. What needs of our own might drive us to consider making similar offerings? How might we learn to receive by giving, or give by receiving? Civic friendship like this doesn't work by the state's command, be and act as friends. It works because it's voluntary. Understanding that, civic friendship might not seem to involve law at all. What does, by contrast, when we think of law in moments of crisis, is legal regulation that involves civic friendship's opposite, civic animosity or enmity. Civic enmity is an idea that may remind us of Oliver Wendell Holmes's lesson that law is about the bad man. Holmes's bad man proves Thomas Hobbes right, that life and nature, being nasty, brutish, and short, involves a war of all against all. The state's job on this view is to exercise its proper monopoly on legitimate violence, controlling the bad man through sanctions that stop or deter him from doing bad things. Law should be on its toes in crisis to the bad man. For him, the sky's the limit, a time for acts that law does or could bar, like price gouging, fraud, exploitation, discrimination, and interpersonal and social violence. Mayhem, that's him. If law is about the bad man, it's easy to suppose legal rules that regulate him are good, perhaps written, enforced, and interpreted by his sworn enemies, good men or good people. These possibilities can be true, of course, but in our political tradition, way back to the founding fathers and before, recalling hard experience, structures of government are widely crafted to handle the prospect that government will fall into the hands of bad men or men who start out good but are corrupted by power. This helps explain why we can so readily think about government as providing for the general welfare and the blessings of liberty, while also thinking about how it constantly threatens them and us. Recognizing these threats, legal traditions, some in the form of constitutional rights, promise to protect us all from a government that would steal our individual and collective freedoms. So, we can praise government while remaining ever vigilant, alert to its dangers. In the present tense, this means being genuinely thankful for the good government from political leaders like Governor DeWine, while keeping our eyes peeled for governmental abuses of power. Hence the struggles over government money, watchdogs, and where medical supplies, including tests, masks, medicines, ventilators, and hopefully soon, safe and effective vaccines will go. We keep faith with our legal traditions by thinking about the government providing these things and also who will get them or other governmental goods like police protections as first responders themselves get sick. We are vigilant because our right to life, liberty, equality, and the pursuit of happiness depends upon it. We have then here a complicated picture in a complicated moment. We have civic friendship and its possibilities, including thinking about law from the perspective of good persons. And we also have thoughts of needing to write law to control the bad man, as well as thoughts about how good government can itself go bad. This complicated picture being basic to how we live together, we can find reflections of it in common rituals, like songs our communities sing. Think here, for example, of the oldest song at The Ohio State University, Carmen, Ohio. Its first verse famously speaks, hearts rebounding thrill with joy, about the firm friendship of Ohio, of which we are all a part. The second verse talks of the good and joys that that friendship can bring in the jolly days of priceless worth, by far the gladdest days on the earth. But then, ominously, in the next verse, we have a sharp shift. Talk of friend turns to talk of foe, as the song paints a picture of sailing on the seas of care neath blackened sky and barren shoal. If the first and second verses remind us of the power of friendship for good and delight, the third reminds us of the perils of enmity, an enmity that's ultimately overcome by thoughts of our beloved Ohio that bids darkness go. If the moral of Carmen, Ohio is that the enduring bonds of friendship may carry the day, this may yet prove to be true of civic friendship in real life. The bonds of relationship and caring for the needs of others and for the community and our collective welfare run very deep. We're apart today, not in person because of them. But these bonds are not yet so deep we can release all concerns about the bad man and a government that can harm us as easily as it gives us a lift. Look at how civic friendship is playing out in national politics. Politicians, so often politically at odds with one another, are coming together as civic friends through relief legislation to make government work for the people, caring for our national political community's needs as we weather the present storm together. What will law look like on the other side? Who can tell? Undoubtedly, it will be some variation of the picture just described, of friendship, of the enmity of the bad man, and of actions by the government that we need to help us, but without violating our rights. What I mean to say here is that one key element is that all that we do now involves how well we can manage to get in touch with and stay in touch with the importance of the idea of mutual aid, which reveals the human condition as a condition in which we all need to take better care of one another, not as others, but as ourselves. This is a lesson that some of our students are powerfully teaching us through their actions. My day job is as a teacher of students. I am also, however, a student of my students' teachings. I hope you will be, I'm tempted to say, I need you to be as well. Thank you.
Thank you. Marc, can those of you who have your cameras on hear me? Give me a thumbs up if you're able to hear me. Okay. You who are the OSU COVID-19 panel. We had Irwin Redlener as our keynote talk, and you just heard from Marc Spindelman, who is Isadora and Ida Topper Professor at Law at the university's Moritz College of Law. We have two more short panelists, and then we're going to open things up for questions. Philip Renaud is the Executive Director of the Risk Institute at The Ohio State University and the Fisher College of Business. Prior to joining the Risk Institute, enterprise risk management functions in a number of diverse industries. His experience extends to management of multi-location, international risk management departments with a specialty in financial risk, strategic and operational risk assessment, and management. Phil, let me mute and hand things over to you now. Phil, we can't. Phil, you hear? Maybe one of our special people in the background can see if we can unmute Phil's mic.
Hi, Caitlin's in here. He's not muted on my end. Phil, can you see on your bottom left-hand corner a microphone that you could click? Can you try again now, Phil?
It indicates I'm unmuted by host.
You're working now. You're good to go.
All right. Okay. Let me start all over again. One, thank you so very much, Dean Fairchild, for the opportunity to be part of this panel. One of the things that I'm going to focus on today is business continuity or critical incident planning from an operational risk perspective. This is not the first event that we faced that requires critical incident planning. Over the last few years, we faced SARS, we faced Zika, we faced H1N1. But as other panelists have indicated before me, surprisingly, we still have not adequately prepared for these types of events. So my focus today is looking at 5 different areas. And some of these are easier said than done in the environment that we're living in today, but 5 different areas that organizations can think about as they plan for the future and plan to operate their respective businesses. I think we need to identify business from 2 different perspectives today. Those part of the critical infrastructure, and multiple states have identified businesses that fall within critical infrastructure, and those businesses that are not part of the critical infrastructure, identified as retail and restaurants and things like that. So if we think about those in the critical infrastructure, supply chain, food stores, healthcare, banking, et cetera, these people are doing Herculean efforts to maintain day in and day out activities for all of us. So with that in mind, I'd like to focus a bit on 5 steps. So the first step that businesses need to focus on is really establishing a critical incident management team. And that team is made up of various people within the organization, from operations, CEO, human resources, legal, etc. And that team needs to establish itself and arrange for daily contact and planning. The next act that needs to be considered is identification of critical activities, critical employees, suppliers, and risk groups. So what activities need to be maintained to ensure business continuity in a critical incident? Think about that. How about identifying essential workers whose uninterrupted presence is required on a day-to-day basis? Next, determine key suppliers and distributors. So if we're thinking about the supply chain in today's day, we talk a lot about just-in-time supply chains. That could be part of the problem we're facing today, because a lot of our critical supplies, gloves, masks, hand sanitizers, are built on a day-to-day environment that is predicted based upon current usage. When current usage is disrupted, as it has been, and it grows geometrically, then the infrastructure that supports those key areas are not necessarily able to ramp up at the speed in which the demand is required. So the identification of key suppliers and distributors to protect both upstream and downstream activities is very important, and we need to get out that early rather than later. Defining risk groups for work-related infection for all employees remaining on-site. So how do we take measures to reduce that risk? In the state of Ohio, and more recently in the state of Michigan with Order 20-02, they're asking that all workers be temperature tested as they come in to the workforce. And I saw this morning that Walmart is also instructing its stores to test workers coming into the workforce from a temperature perspective. What does that create? It creates people being faced with activities that are not within their normal skill set. For example, if we're asking people to come into a distribution center and asking someone in a distribution center to take their temperature, albeit no contact, what is the training required for that person to take that temperature? They're not medically trained. They're not nurses. They're not physicians. Do we have the right personal protective equipment for those people? Have we identified the right screening devices? More importantly, are those screening devices and are those personal protective equipment available in the current marketplace? So C, how do we effectively manage infected employees with the resources required for treatment? How are we identifying people that may be affected in the workforce, and how are we treating them? How are we asking them to shelter in place or seek other medical treatment? And more importantly, how are we protecting the people who remain in the workforce? These are critical workers, remember, to make sure that they're protected from any potential infection down the road. We then move on to thinking about reduction of activities and developing a communication plan. So we need to make sure that we're communicating with all of the associates out there and developing a plan to reduce activities on a stepwise basis. So there could be a point in time where certain industries are really only functioning with basic safety and security functions in order to maintain their business. Think about the security of critical products that are in those warehouses or in those stores or in those other distribution centers, for example. They could be subject to criminal activity, as Marc indicated in his presentation. And deciding on effective and responsible communication to all to make sure that both our internal customers and our external customers are impacted and communicated appropriately. And then lastly, we think about business recovery. So this will end, and how do we then bring upon an orderly transition to normal business activity? We're not going to flip the switch and suddenly tomorrow we're going to have normal business activity, but it will occur, and we need to think about that and how we resume business activity in a normal and organized fashion. Thank you.
Thank you, Phil. My other panelists, can you still hear me? Good. So that was Phil Renaud. He is the executive at the College of Business. We're going to include remarks from our speakers with Dr. Andy Thomas. Andy is associate professor, and Phil, I think you may need to mute now. He's associate professor of clinical internal medicine at the Ohio State University College of Medicine, and he serves as the chief clinical officer for OSU's Wexner Medical Center. As Chief Clinical Officer, he is currently focused on running the clinical response and he and Elizabeth Seeley, our Chief Officer, are leading the charge regarding coordinating the planning effort. So this is a very nice group to a person to follow up on thinking about how we transition back and how we respond. So I'm going to mute Andy and hand this over to you.
Thank you, Amy. Thank you very much for having me. Can someone give me a thumbs up if you can hear me? Just to make sure it's coming through okay.
We
Excellent.
can hear you.
Great. Thank you. I want to focus on just 4 things, but first just to step back to where we were really just, little over 2 months ago. Just to remind people, it's just January 21st was the first case in the United States. And actually on January 22nd, we had over 80 people on a conference call the afternoon of the 22nd from across the university. Luckily, we have the benefit here of having a really experienced team, both not just at the medical center, but also in student health, student life, College of Public Health. We even had folks from the athletic department, Bob Armstrong, who's from University Emergency Preparedness. We've all worked together for years, so it's nice that it's the same group that worked on mumps, it's the same group that worked on Ebola, it's the same group that worked on Zika and H1N1 for the most part. And it was like calling the band back together, but this time it seemed like it was something that was actually going to be a major problem here for us. It's also important to remember that it was just 4 weeks ago today that Governor DeWine and Mayor Ginther made the difficult choice that at that time seemed incredibly extreme of limiting spectators at the Arnold Gala. It's important to remember we did not have a case in Central Ohio for another 10 days after they made that decision. It's pretty forward thinking at the time to think even 10 days before we had a case here locally that we were already starting the concept of social distancing. And at that time, there were only 42 cases in the state of Ohio, most of which were in the Cleveland area. So a little bit just in terms of preparation. From the university's perspective, so I'm not just Chief Clinical Officer for the Medical Center, I'm also a Senior Associate Vice President for the University for Health Sciences, and really work broadly with our colleagues in HR, communications, public health, as I mentioned, student health, student life, all the time around the health of our community. But the university has to prepare really in 3 different ways. We are a large employer, one of the largest employers in the region, if not in the state. We are also a medical center, so we're a provider of healthcare, not just for our own community, but more broadly for people from around Central Ohio and the entire state. And last but not least, we're also a community where people live. We have dorms, we have individuals who live in apartments around the community, and we need to be prepared kind of from all those perspectives. So one of the things most people probably don't know is we do routinely do drills with a group called the Central Ohio Trauma System. They pull together individuals from across the region. We do drills. Sometimes it's around a terrorist attack. Sometimes it's around a plane crash. A tornado hits a Kroger. And we've done also pandemic preparedness. And we do usually 2 to 3 of these drills a year. We use, was mentioned earlier, the idea of incident command structure. We use what's called the HICUS structure, or HICE structure, the Hospital Incident Command Center, which grew out of one of the major earthquakes back in California, I believe it was in the late 80s, early 90s, where they developed a hospital-focused incident command structure that now has been kind of nationally adopted by almost all hospitals. And we have down to very specific job descriptions for different roles. And we pull that out, like I said, 2 or 3 times a year with real drills where we actually even talk students into launching up with blood on them, and we triage people in the ER, and it's done with first responders in the community. It's really interesting work. So with all that as a backdrop, when these sort of events occur, we really use a just-in-time education methodology. You can imagine, in this case, it was a novel coronavirus, so we wouldn't have even had the opportunity to learn about this in medical school or nursing school. But even if it's something, we had a botulism outbreak, for example, in Lancaster a number of years ago related to a church festival where someone had brought bad potato salad. We had to get all of the Central Ohio hospitals plus our own staff internally educated, because we just don't see mass cases of botulism routinely. So we have a just-in-time education methodology where we relatively quickly try to get information into the hands of people based on what we know. So for example, On January 21st, the first case was diagnosed in the United States. Our epidemiology and ID team had been following this. I believe my first email was around January 6th or 7th about, hey, there's this thing happening in China we're hearing about. We're going to keep following this. Nothing to do now, but be prepared. We had the first case on the 21st. We had our first meeting on the 22nd. Our first communication to providers went out on the 23rd, and a university-wide email went out on the 24th that just set the stage for really where we are, gosh, 9 weeks later. So that just-in-time education really, for the case of our providers, starts out with one of these international epidemics as really how do we screen? So how do we find someone who's the random traveler from China and they have these symptoms? So we use our computer system to get out very quickly to hundreds of registration clerks across the system, whether they're talking to someone by phone or registering in the office, a set of questions that they ask, and if those flag positive, it's a really simple 4-step process. Slide the patient a mask, have the patient go in a private room, close the door, and call this number. It's really that simple. That allows us relatively quickly to find that stray traveler or that stray person who's been exposed and is sick to jump on that quickly. Because our goal at that point is screening and protecting the other people in the office and the other staff. You've already heard a little bit about testing. I share the frustrations of many of the folks on the panel that we did not test people earlier in Ohio. We did not actually even have test kits available in the state until March 7th. You could send tests off to CDC, but the patient actually basically had to be admitted to the hospital, which is rare for this condition to even get people tested. So we had no one tested before tests were available in the state. Now, one thing I will say, though, about testing, a comment was made earlier, there are 27,000 people in Ohio that have been tested. I think most of the folks on this call would be surprised to know that at Ohio State, through our own testing sites, we've tested 4,552. So 1 out of every 6 people tested in the entire state of Ohio wasn't just tested in Columbus, but was tested at Ohio State. We've started that testing on March 9th with 3 people. By a week later, we were testing 300 people a day. We have a large tent over by the Crane Sports Medicine Institute off of Ackerman that maybe you've seen. It's a drive-through or what we call curbside testing program. And we're actually quite proud of how quickly we've been able to ramp up in screening at our peak over 400 people a day. In terms of positive tests, we actually also have about 12% of all the positive tests from the state of Ohio have been done through our testing program. But we've now moved really from this screening and how do you find these people to really how do we treat these people. We now have people in the hospital, both in the ICU as well as in med-surg step-down units. We've had people that have been admitted and discharged. We had people that are still in for lengthy admissions. And we're now moving to how do we treat and take care of these people that are sick. And I'll talk for a second about how do we surge our capacity. The third thing I did want to mention, it's already been mentioned briefly, is supply chain. This was a relatively unique incident where not only did the virus originate, or the original infections originated in China, but obviously that's a lot of where our supply chain comes from, everything from medications to medical equipment to certainly personal protective equipment. Most people hasn't really been as much in the news, but one of the major suppliers of the swabs that we use for testing individuals are actually made in Italy. So those were also hit by the supply chain in some ways just as much as the personal protective equipment was hit. The good news is that manufacturers across the state of Ohio and across the country have really stepped in to fill that gap in terms of especially how we will be making personal protective equipment in the U.S., I think, moving forward. One of the other key things I don't think that's been mentioned is Battelle has also been a great partner in this, not only on the testing side, where we partnered with Battelle and we're now able to test more than 1,000, process more than 1,000 tests per day, and are actually starting to offer that service to other hospitals as of this past week. But also Battelle has stepped up working with us and Ohio Health to develop a way so we can recycle personal protective equipment, especially the N95 masks, which are the most protective masks that are out there. So that FDA approval was just received just in the past few days. And last thing I'll finish on is just how we go about preparing and planning for surge situations. Every hospital has a variety of surge plans that are created based on whatever the event is. You can imagine a trauma event, you need different types of rooms, different types of staff. an epidemic event, very different, especially one that leads to people needing ICU level care. So when it comes to surge, we talk about the 3 S's. It's space, staff, and stuff. It's really how you try to prepare. Where do you go from the routine places that you provide care all the way up to going outside your walls? So level 1 surge is essentially looking at maximizing all of the places where we routinely care for patients. So for example, the Ross Hart Hospital is built as a uniform ICU hospital. So all 150 beds in the Ross can be used as ICU beds. Normally on a day-to-day basis, we don't use them that way. We use maybe 45 of the 150 as ICU beds for heart patients. We're in the process of moving patients around so that we can utilize more of those beds because the space is created as an ICU space. Now we just need to make sure that we have the staffing and the stuff that we need to care for those patients. So level 1 surge really is about maximizing your usual sites of care in a hospital. Level 2 surge is really about maximizing spaces that you wouldn't normally use for that sort of care. So for example, that would be using a procedural recovery area or what's called a PACU, or post-anesthesia recovery area, where you go after surgery as an ICU, or using an operating room as an ICU. So it's a space that's outfitted to do that, but it's not something you would normally do. Using, for example, our old bone marrow transplant unit on the 3rd floor of the old James, which is now the Brain and Spine Hospital. It's now an ambulatory surgery prep and recovery center, but those rooms are still built to be ICU rooms. So we'll be able to move back into them as ICU rooms if the surge hits where we think it may. Level 3 surge is really where hospitals go outside of their walls. And some of you probably seen reports in the press this past week. We made a decision about 2 weeks ago, along with my colleagues from Ohio Health and Mount Carmel, that if any of us need to go outside of our walls, we would like to do that in a co-located fashion with them. So we've looked at dorms, we've looked at hotels, we looked at the Schottenstein Center or the Nationwide Arena downtown. We decided instead of each of us standing up 3 independent level 3 surge sites, that we would do that all in one location. And we picked the Greater Columbus Convention Center for that. Essentially what we'll have is a set of services that the convention center will support in terms of some food services and trash hauling and so forth. Some services that we'll all jointly contract on together, things like oxygen. We just need one vendor to deliver oxygen to the facility. But then we'll actually run 3 co-located between 200 and 300 bed hospitals in that facility. That will be, one group will be Ohio Health, one group Mount Carmel, and one group Ohio State. Mainly because we have different electronic medical records, we have different pharmacy systems, different lab systems. So there'll be essentially a closed loop for those systems so that we can effectively still use our computer systems, which provide a variety of patient safety factors for us, everything from registration even to revenue cycle, as the presentation earlier was talking about business interruption and so forth. So the level 3 surge really is about how we get outside of our walls to provide care at a different site in the community. The last thing I'll touch on is the work that's been done over the past couple of weeks around how Ohio as a state responds to this crisis. So the emergency management agencies across the state are set up into 8 regions from a hospital perspective. We happen to be in Region 4 here in Columbus. It extends from the contiguous counties around Franklin County up to the northwest, basically up towards Bell Fountain, if any of you know where Mad River Mountain is. And then areas 7 and 8 are in southern Ohio and southeastern Ohio. We have effectively function as one region for the purposes of something like this. So there are 42 hospitals across those 3 regions. And we have a core team now that's meeting that is essentially coordinating the flow of patients across those 42 hospitals. Similarly, in Cleveland, there's a group that looks at the northern Ohio and kind of down to the Canton-Akron area hospitals, and then there's a Dayton and Cincinnati group. So the 8 regions are essentially split up into 3 zones, kind of a northern, a central, and a southern zone. And then we create what I like to call an air traffic control methodology, where as we move patients between hospitals, we do that in a way that's coordinated. So not any one central referral hospital is getting all the volume and someone else is sitting twiddling their thumbs. So it's the first time in my experience that we've actually gone to the point of actually having to pull that off the shelf and implement it. So we're working through those practices, but those relationships have already been built and exist. In fact, we had our first conference call of all of the CEOs for those 3 regions, 4, 7, and 8, on Saturday, just looking at the surge that's coming over the course of the next month to make sure that they all understand there's a plan. Columbus, the major medical centers here in Columbus are here to back them up, because obviously you can imagine many of the hospitals, especially in southeastern and eastern Ohio, are critical access or a step above that, but they don't have intense ICU and other things. So that's just a little bit of the work we've done here at the university within the medical center, and then at the community level. Now pause there.
Thank you, Andy. I'm going to try stopping my video to see if that helps with my audio just a little bit. I'm getting an internet connection unstable. Can all of you still hear me? Give me a thumbs up if you can hear me. Maybe what you can do is the first person who I'll pitch the question to can repeat it in the event that somebody does not hear it. And Irwin, I'd like for you to start on this one, and then I'm going to ask each of you to weigh in. So a lot of
Amy, can you hear me and see me?
Yes.
Oh, I'm amazed. Okay, there you go.
All right, excellent. So, one of the things we have heard a lot, especially lately, is the cure can't be worse than the disease. Is this even the right question to be asking? And how do we help people, how do we help respond to that worry?
It's a very interesting question. And, and it is something we need to think about in a particular kind of way. Because what we're asking people to do is basically change their entire lives, the way they live, the way they work, the way they interact with their families. And I think the question really amounts to, is that kind of isolation going to result in things that are unpredictable, like exacerbation of mental health challenges, people with severe anxiety or depression that are now being told that they can't go out, people who may have had issues with problems with partners that they need to be in now 24/7 with. I mean, are people going to get so depressed that we'll see increasing suicide rates? And I think that that's something that is worth thinking about. We're going to need to deal with this, and that if we go on for a long time, sorry about that, guys. If we go on for a long time with these kind of very strict guidelines, which we may need from a public health point of view to get control and keep control. Oh my God. Okay, this is the hospital. 1 second, excuse me 1 second. Yes. Yeah, I'm on a conference call. What's up, please? Who's this? Okay. Please call me in 10 minutes. Please do. Absolutely. I'm so sorry. So anyway, that's what they mean by, is the cure worse than the disease? And especially if you start getting to the realm now of medical countermeasures that are not proven, we have a whole series of things that are maybe very challenging. The problem is that we don't yet know how to fully adapt. I think the public is doing actually quite well, but we don't really know how to adapt to this new surreal world that's been created. So my therapy for this challenge is to make sure that we've done two things. One is that we've given wonderful, effective guidance to families for how to cope with this. And there's lots of things that can be done. My grandchildren are getting schooled at home. They're using remote. They have a schedule set up. They're doing arithmetic, and then they're doing reading, and then they're doing whatever else they need to do. And they have recess, et cetera. And their parents are doing, in some of the cases, a pretty good job. What I worry about, though, are the people that I said earlier that do not have a financial reserve to carry them over. They're not just worried about the fact that they're isolated. They're worried about the fact that they won't be able to pay the rent. What happens if I get, evicted? They're worried about, can I get food for my family? Can I get the medicines? Will I have the co-pays I need? That is something that's fixable. So one of the public health answers to this, whether the cure is worse than the disease, is fix that part. Have the money that's coming from the federal government really deal with the actual financial needs of families that are affected. And I think that'll go a long way. That's sort of the best I can do with this, but others should weigh in too.
Let me just do a quick mea culpa, because I had promised that President Michael Drake would get the first question. So let me put that question on hold, in particular because I want Michael to get a chance as an old friend of Irwin's to say hello, ask a question, and then I will pitch both questions around to different panelists. So President Drake, are you on?
Yeah, I'm here. Can you hear me? My picture's an icon, so, but do you hear me? Good, okay, I see Andy, so great. So I'll talk and pretend that I'm centered, although well, I won't say. So a couple of things I want to say at the very beginning. First, everyone who's on the call, thank you. For those who phoned in, thank you. And those who've been part of the panel, and Amy, thank you so much for doing this. Everyone, as Irwin was just saying, everyone's life was really disrupted. And I want to just take a moment on a human scale to make sure we all kind of feel connected, and that we're traveling through these new uncharted stormy waters together, and all trying to do our best to receive information and make the best judgments we can while taking care of ourselves and worrying about our families. So it's a lot, and I just wanted to thank everyone for the time and the focus. And then I have 3+1 questions that are sort of straightforward. So I'll start with Dr. Redlener. Irwin, nice to see you. I wish you were closer, but nice to see you. And just say a couple of things though. So here it is today, Tuesday, the 31st. And if you were going to give, little bits of advice, what's the best thing for individuals to do these coming days, this coming week? What would be the best thing for universities and health centers like ours to be doing this coming week? And what's the best advice for our governmental leaders this coming week, and to help us to get ahead of this? And I have a follow-up after that.
Okay, so I think the most important thing for families, for individuals, is to try to get used to this new reality and adapt your lives to help make sure that you and others don't get COVID-19 as best as you can. And what that means in practical terms, Michael, is that people need to settle in, write down a schedule for what you want to do, make sure you're leaving a lot of time for emotionally supporting your family that's around you. If you're a parent, it's really important that you understand that you are a buffer for your children from the incredible influx of news about the situation. You need to step up to the plate and fake it. If I know we're all anxious, so let's just say that. But for parents in particular, I think you just have to kind of force your way through this, but enjoy your children, enjoy the extra time. Hopefully you're in, that everybody's in pretty good shape in terms of relationships in the family. But call if you're not, and there's issues that you think you can't handle. And that's what it is. Try to create yourself a new reality for your lives for this particular moment in time. That's there. Institutions are doing a fantastic job. And Michael, you and I have talked about how the Ohio State University has taken all of the appropriate steps. People need to pay attention and follow it. And for students in the universities, they're going to have to get used to being students remotely. And this is not the first time. We have all kinds of universities, including the Ohio State, that does remote courses and maybe degree programs. I'm not exactly sure what you're doing, but just figure it out. Feel very happy that you're in an age where we have access to this incredible remote capacity. So don't let your education slip. The university is doing everything in its power to make sure it's as easy as possible without actually getting together to continue your education. As for government leaders, do you have another hour or so? I guess I don't, but let me just say this. There's three things for the government. One is, at some point, there's going to be a serious postmortem about what went wrong with this from the federal government's point of view. They left, in essence, because of incredibly confusing mixed messages that come from the White House and so on, that it forced governments, state and local governments, to kind of wing it, to do it on their own without consistent guidance from the top. That's unfortunate. Hopefully they're getting that act together now. I'm not exactly sure, but that's one thing. Second of all, this fiasco of developing the testing so late and so poorly does have big consequences, and I think they're sort of getting it together. The most important thing for political leaders is protect our healthcare system and our healthcare workers. they are on the front lines, much like military troops that are deployed to Afghanistan or Iraq. They are in immediate danger, and they are going to work every day anyway. And we no matter what, we have to make sure that you political leaders make sure that the supply chains are fixed, and that no doctor, nurse, aide, dietitian, respiratory therapist should go to work without having their appropriate personal protection taken care of. 2 military officers with serious battlefront experience told me because I called them last week, a couple of guys I know, and one of them said to me, for a doctor or nurse or other person in the hospital to go into an emergency room now where there's a hot spot without appropriate PPE, quote, would be like me going without body armor and my M16 and reinforcements for my Humvee. That's what it would feel like. And as a parent of an emergency medicine doctor, I will tell you there's nothing more important. It's not just because my son is there, but because thousands and thousands of our healthcare professionals are literally putting their lives on the line. And politicians need to pay attention to that as a first priority, in my opinion.
Thank you very much. I said I had a follow-up question also. So this is maybe for Michael Oglesbee more, but I'll tell you the follow-up question. We predicted what the curves would look like, what the surge would look like if allowed to occur naturally. And if I just interpreted back of the envelope, it cut roughly in half by social distancing. And so my question is, that's the predictive model of social distancing as we're doing it. If whatever the maximum theoretically possible social distancing were possible, what would the curve look like? And then is there a space between where we are now and that maximum that's reasonably achievable? Are we the most socially distant that we can think that we could get? And if not, how much of a difference would that make?
In looking at the curves, we're actually hoping that by mid-May, the first week of May, we could get the number of incident cases down to almost 0. And hopefully that's addressing your question. And to transition that a bit, when we talk about new normal, I don't think we should take our current situation as constant. It's going to change dramatically. So I would envision that our measures are going to change as we end up on the other side of the curve. And again, with enhanced testing capacity, we could do more contact tracing, and we could look at outbreaks, and we could focus on containing those outbreaks and not having to go with a global, everybody shelter in place. And also, again, with the serologic testing, and my understanding is that the diagnostic lab in the Wexner Medical Center hopes to have a validated serologic test by mid-April. I don't know how long it'll take to deploy that, but that'll be a huge asset in terms of modifying how we respond. Does that answer the question?
In one way it does, yes, and I appreciate that. And the other part would be, is there anything more that we can do in the short run to flatten it even more, or are we at the theoretical, practical maximum where we are now?
Michael, sorry.
No, I appreciate that answer. Yes, Irwin, you were going to say something.
Yeah, I was just going to say that if it was up to me, I actually would recommend a full national shelter-in-place program for some period of time to be determined by some other factors. But I think if we really wanted to get control of this, that is what I would do. But even if we did that, there's some other sort of disturbing realities. I'd like to know what Michael Oglesbee has to say about this, but I think you may have mentioned it earlier, but I had to get off. But we're not clear about whether people are actually going to be resistant to a second or third infection, because there's some really kind of complex realities about this particular virus. And it may be that most of us who catch it, mild or otherwise, will have limited time of actual immunity. It certainly won't be lifetime, but If that is the case, then the answer is going to be a vaccine that works, but which is it's a particularly complex challenge to make a vaccine, but for this particular disease. But the fact that we won't have much persistent immunity is distressing, which of course suggests that we may have longer periods of sheltering in place than we think. On the other hand, you could say, all right, everybody out, go back to work. Whoever's going to get sick, we'll care for them. Maybe we'll have some medical countermeasures, but I'm not sure that I would not agree with that either. But I think some prolonged period of a national shelter in place is where we're going, or maybe where we should be going. But Michael.
Yeah, no, I agree that the immunity established will likely not be lifelong, but what we know from the first SARS and the Middle Eastern respiratory syndrome virus, we can expect short-term protective immunity. And I can't really put a number on what short-term represents. Could be months.
Yeah.
And so even with the, once the vaccine is developed, one of the, targets of that vaccine would be recovered individuals to boost the level of immunity that they've established from natural exposure.
So Michael Drake, this is what Michael Oglesbee is just saying. And when I also, it's one thing for public health pundits like myself or scientists like Michael Oglesbee to give you this information we just gave you. How does that translate into public policy? And I think nobody's clear about that. I know for a fact that Governor Cuomo in New York and Mayor de Blasio of New York City have people whispering in their ear 24/7 with different perspectives on what the science says or is worried about, and what does that mean for the press conference that they're having every day? Right. And that gap is a critical challenge because they have to say something, and we're saying, well, we're not sure, maybe this, maybe that, and I'm as guilty as the next person of being, in the not sure category, but I guess I'm allowed to be not sure, but the governor, the president, the mayor is in a far different position. So Michael Drake, I'd just be curious what you think about that. How do we deal with that communication issue as it relates to what Oglesbee and Redlener are saying and other modelers versus what should be coming out of the mouths of political leaders, which actually matters?
Yeah, I'll give you an answer, and that's the answer that I've been using these days. Is I've said this before, if I see you at 20 feet offshore and you need a rope, it doesn't do you any good if I throw you 15 feet of rope or I throw you 18 feet of rope. But if I start and throw you 15 feet of rope and I see that that's not enough, I'm going to go back and maybe get you 25 feet. But by that time, you're 30 feet offshore. And so what I think that we should do is if I think you're about 20 feet offshore, throw you 30 feet of rope, pull you in first, and then if I have some more rope to pull in, fine. But don't make it that I give you less than you need at the beginning and then hope that I've gotten enough and try to catch up. Because once the horse is out of the barn, the horse is running faster than we are. And we can know what we're trying to catch, but it's hard to do. So I would say in general that I'd like to look at what's the most that we can do that's likely to continue to have an effect, get there, bend the curve as flat as we can get it, and then at an appropriate time, release a little bit of that, release whatever the restrictions are as we see they're safe. And Michael Oglesbee, you spoke of the limited immunity, and boy, there's a real difference if that's 3 to 6 months versus 2 or 3 years. And so we'll know those kinds of things as we go forward. But the first thing it would seem to me to do would be able to try to limit the curve as much as we could, flatten it as much as we could, not overwhelm the health system. Try to get over the hump of new cases, see that that's working, encourage people bit by bit to say, you have to stay in there, hang in there, hang in there, hang in there. And then as we get to a lower place, start to release the restrictions in an appropriate fashion. And I do think we're going to have a new normal. I've likened it to what it used to be like getting on an airplane. And you'll remember the Eastern Airlines shuttle. You get on the plane and buy your ticket on board. And we've gone to something quite different from that now. And I think that for international travel and other things for coming to work, we'll have different standards of making sure you're okay before you get together with a lot of people.
You, sir, should be whispering in those political ears. You should. No, I think that's a great answer. And yeah, we're all struggling with this, but that's a really good way to put it. So thank you.
If I could for a moment, I'd like to open this up to some of our other panelists. So I'd like for, I mean, in particular, we have a lot of questions on the table, but Irwin proposed put his money on a full national shelter-in-place strategy. So, but we've had some other questions. So I would like for Phil to weigh in from an economic perspective, Andy to weigh in from you know, a clinical perspective, and then Marc to weigh in from a legal perspective. So if we could go to Phil, Andy, and then Marc, that would be terrific. Okay, we can't hear Phil. Phil, we can't hear you. So I'm gonna go Andy, Marc, Phil. Okay.
Can you hear me now?
Okay, we can hear you now.
Thanks, Dean Fairchild. You know, we've got significant challenges in front of us from a business perspective, right? As businesses now start to lay significant amounts of people off, and a future risk of some of those people coming down with COVID-19. The infrastructure that we have created, and I'll call it the infrastructure related to risk management and insurance, wasn't built for this. Let me give you a good example of that. Workers' compensation. Workers' compensation insurance is built around injuries or illness arising out of in the course of employment. Is the industry going to define this as arising out of in the course of employment? A next challenge is there's what we refer to in the industry as business interruption insurance. Business interruption insurance was triggered or is triggered based upon physical loss or damage to the building insured. Again, it wasn't built for this. So I commend Ohio, I commend New York, and I commend Pennsylvania, who have all taken some action to look at these various features and say, we need to do something to lessen the burden on industry and make the rather onerous provisions that exist in policies out there today a little less onerous on business so they can survive and they can flourish as we come out the other end. These are big challenges and will cost a significant amount to the industry being insurance industry.
Thank you, Phil. So Andy, can I get way in, and then
Sure.
Marc?
Sure. Two things I'd say. First of all, just on the modeling in general, and I can say this because these folks don't report to me; they report up to our colleagues on the call. So I can say this. I can tell you that I've been incredibly impressed with the modeling team out of the Infectious Disease Institute, Elizabeth, Joe, Gregor, the team. I've seen them present both internally to our team as well as to literally the entire Ohio Hospital Association last Friday. There are other people in the state that are trying to do similar modeling, and I can tell you from all the public policy folks I've talked to, that everybody feels like our model is the best and is very well respected. Has actually become the basis for a lot of the work the Ohio Hospital Association is doing and putting out to other hospitals. So that's just a pat on the back, really, for just excellent academic work by mathematicians in working with colleagues in infectious disease and other areas. In terms of the national stay-at-home, I think that certainly I know just from talking to people who run businesses, the complexity of within states, like in Missouri is one example, each county was doing a different thing. That makes no sense at all. I think if you lived in Toledo and Michigan didn't do something, that wouldn't make any sense either. So I do think that some sort of a national stay-at-home order makes sense to me. I don't know the extent to which you would be able to enforce that across the entire country or the timeline at which you would stop that. But at least it seems to me anything we can do to push out the curve and to flatten it is beneficial for all, but not just patients, but hospitals, providers, as we've discussed across the country. Try and make that, instead of that yellow curve, make the blue curve so that it's less amplitude and less slope.
Thank you. So Marc, I'm going to pitch it. But can I add one question, but one thing before you go, because we've also had a question about, so let's imagine we have a national stay-in-place order, and we'll see what you think. But if we do, what do you think about arresting those who violate shelter-in-place?
I think, there's certainly a strong case that one can make in favor of a national stay-at-home protection order, not least of all that it resolves some of the coordination difficulties and kind of mops up and sort of makes a national rule that rationalizes the approaches across jurisdictions, elevates it in a sense from the local political arena to the arena of expertise in public health and public policy. But as strong as I think that the case can be, that can be for a national stay-at-home policy, I guess I'm really struck, sort of in general, but then also listening to some of our, to Irwin and others, about how difficult it actually is to figure out what all of the variables are that go into the kinds of cost-benefit analytics that actually drive the policy, not simply the public justifications for it. And so, I'm struck by the significant uncertainties of various sorts. Knowledge about the disease, how it's moving, knowledge about the displacement effects that Irwin talked about, the effects of sort of the surging in relation to COVID patients and the impacts that that's having on lots of other patients. There's so much uncertainty. I can easily imagine policymakers not quite feeling as though they can get their arms fully around it, even talking to the experts to know which experts on what topics, not just public health, but more generally, to listen to and how to factor all of that in. I think as far as the question of arrest, we're not away from the problem of transferring vulnerability to populations that are often vulnerable. Who is it who would be violating a policy? Is it sort of an ordinary bad man whose actions are independent and autonomous, just a bad actor? Or is it somebody who's moving in space and time for reasons that have to do with pre-existing vulnerabilities? And what is it that we're actually talking about when we're talking about potentially incarcerating people? And what are the conditions of confinement and the risks there, which are not, again, only risks to the populations who are being held under those conditions, but probably, quite certainly risks to the wider population through the ordinary vectors of who's moving in and out of those spaces, not only prisoners, but people who work there. So these problems are, massively complicated in many ways. And even though I think President Drake's sort of vision of thinking about this in terms of a rope that you want to have sort of plenty of room for the first time you throw it out, that makes a lot of sense to me. But, it's hard sometimes to measure the full costs of lengthening the rope early on. And so we're moving in the absence of lots of knowledge with a certain amount of faith that what we're trying to maximize is sort of the benefits to the pressures on the system. Anyway, it's so complicated.
Thank you, Marc. So I'm looking at our time coming to wrap up here, and I'd like to ask a final question. And President Drake, I'm going to ask you, maybe if you'll be the last person to weigh in on this question. It looks like we may have lost Irwin. I don't know if you were on earlier when he said that his son has been hospitalized. So, and he warned us that he could get off. But I think he gave us some of these lessons. So I'm just going to go around the horn here. And Mike, I'll start with you. I'll come down to Phil, Andy, Marc, but then President Drake, maybe end with you. What is the most, if you have one single lesson you want us to take away from the COVID-19 pandemic, what is it?
I love the question. What I'm frustrated by is communicating the importance of preventing something that is not immediately on your doorstep. This becomes I suppose it's a topic for risk communication. It's communicating science, but people, when the problem's gone, all of a sudden, investing in preventing the next occurrence becomes a progressively lesser and lesser priority with the passage of time. But we have to come up with a way to illustrate the importance of preparedness. And I think that's what Andy was getting at with some of the exercises they have going on in the medical school. But the whole public needs to be exposed to this and appreciate that.
Thank you. Phil.
Yes. Yeah, I mean, I think one thing that comes to mind is empathy, right? We need to think about being more empathic as a society. We need to understand that there are people on the front lines here doing their job every single day of the week that are exposing themselves, people in the supply chain, food, healthcare, on and on. So we need to think about those people and make sure that we're caring for those people when people are on the front lines every single day. The last piece I'll raise is we need to be prepared. We need to think about this not in terms of a one-off event, but this is a series of potential problems that we as a society are going to face down the road. You know, we talked about SARS, we talked about H1N1, we talked about Zika. My words are that we need to think about this as not one of one, but one of potentially many, and be prepared and think about how we're going to plan, think how we're going to prepare ourselves as families, and also prepare our businesses.
And thank you, Phil. Andy.
So that's tough. I think the empathy comment earlier really strikes a chord with me. I think that probably the one thing that I just am continually reminded by is the heroism of the people that I work with and the loyalty and the commitment of them. I was in on Sunday night, as President Drake knows, we had a difficult weekend for a variety of reasons. And I was then meeting with the staff in the emergency department prior to the 7 p.m. Evening shift. It's a 12-hour shift that goes till Monday morning. And I went by their huddle. I was just walking around checking on some of the units. And I spent just 3 or 4 minutes thanking them. We have their back. They're the ones on the front lines. I just make phone calls. They're the ones that are gowned up, gloved up, and masked up, going in and taking care of patients. And it's just that the heroism on a day-to-day basis of those people and the commitment and the loyalty, both to their patients, to each other, and certainly in many ways to the university. It really just, you pinch yourself and realize these are actually people that do this every day, whether it's a trauma or whether it's some other patient that's come in with some other issue, whether it's an ICU nurse, an ICU doc, a floor doc. It's just, it's been incredible, the heroism of people.
Thank you. So, and we've only got a couple of minutes left. So if we could be swift, Marc, and then I'll give President Drake the last word.
Sure. So I think I'm with Phil and Andy. I think that part of the takeaway, the message, the lesson, the teaching here is one of what our values are and how we take care of one another. As I was saying, in friendship, there are, of course, the acts of heroism that Andy was just describing. But I guess what I've been struck by talking with students, with colleagues, with friends, with neighbors, with strangers, are all of the small ways in which people are attending to one another in a moment of difficulty, sharing stories, playing games at home with family members that they might not have had occasion to do that with before, sharing time, sharing conversation in ways that make it possible, in a sense, for people to rediscover one another in new and different sorts of ways, so that the simple acts that we take for granted, spending time with friends and loved ones sort of outside of our immediate families, become acts that are imbued with a new form of meaning that we might have forgotten about or might otherwise, under happier circumstances, take for granted. So for me, it's a question about the values and how we meet the moment as a way of helping one another through a difficult time.
Thank you, Marc. Dr. Drake?
Yes, so first, again, thank everyone for all the effort to come together like this and all the great work that everyone is doing in all the different ways it's happening. It really is inspiring, and I appreciate that. And I have a couple things I used to say. First, I work with a group called the Commonwealth Fund, and we are looking actively at the healthcare system in the United States and have been since 1918. Interesting time for the fund to start, and are really thinking about helping the health system to be more resilient in the future. So that's the future thing. The thing today that I think about is that excluding your family members, that if we take an individual, you can't catch the virus at home. So when you're home, you're not being infected, and so you're safe there. If unfortunately you already have the virus, you can't spread the virus if you stay at home. And so my advice to everyone is that the first thing you need to do is to stay at home and not catch the virus if you don't have it, and not spread it if you do. And that's a good starting place if we're going to bend the curve to make sure that it gives all of us the greatest amount of time to deal with this effectively in the future. All the other things we've heard today are really great food for thought. We've got a lot of work for us today and tomorrow, a lot of work next week and through the next month, but I really appreciate the different points of view that everyone brought to the discussion, and I know that we're all focused on getting ahead of this and getting around that corner and getting back to more normalcy. Thank you so much, Amy, for hosting this so well, and I'll thank everybody for joining.
Thank you, President Drake. Let me also thank everybody who contributed today. Let me thank the people behind the scenes trying to fix our technical difficulties. That was no small task. And let me just conclude by saying in a slightly different way a point a number of people have made, and that's public health is the normally invisible foundation for healthy populations. This has exposed the ways in which we have a lot of collapse at the foundation, and we need to continue to see and invest in public health infrastructure in a way that's not only about preparedness for pandemic events, but that supports and protects us day in, day out, year in, year out, really ensuring that we're all in this together by building strong, fair, nimble systems that prevent crises and empower communities. So with that, let me thank everybody, and thank you for the time and joining us. And there are a number of questions on the chat. Perhaps panelists can take a look at those, and when they see the ones that are specific to them, try to answer them. Thank you again. Thank you all.
Thank you.
Thanks, Amy.
Thank you.